Okay, thank you very much. I was just at another conference last week talking about these subjects, but it was a hybrid conference, and switching between all the different systems. I'd gone for about 20 minutes, and finally someone said, "We don't see a single slide." I'm like, "Well, that's okay. We'll just back up and start again." But so it's always good to get that feedback. So this talk is more focused on strategies for using the jet. There will be there'll be some background, but not so much focused on how the jet works per se, but more understanding some of the studies that were done and when they apply and when they don't apply. So again, we're going to focus on strategies for infants now as low as 21 to 25 to 26 weeks. There is data showing that once you're at 27 weeks, volume targeted ventilation has the same equivalent outcomes. And again, one of the key things with the jet is what device you use to support the PEEP and to give the side breaths. And the background flow of that device is pretty critical for the jet to be able to work optimally at very low settings. And again, just to show you first intention, this was a 21 and 3/7 week baby. I think he's 4 or 5 years old now. And you can see first intention is when we get back to the unit, so about 10 minutes of life, and you can see the high pressure jet tubing right there. Nothing to disclose. So the objectives are going to focus on the effects of changes in jet rate, mean airway pressure, jet peak pressure, conventionally generated PEEP, and side breaths on ventilation and oxygenation in neonates with respiratory failure. We're going to talk about developmentally appropriate strategies for the use of first intention. And the whole goal is always to be neuroprotective of our pulmonary approach. The goal is not to have an IVH, not to have PVL, versus if the choice is to have that, I don't want to be off oxygen at 36 weeks PMA. I'd rather be on some supplemental oxygen at 36 weeks PMA with an intact brain, intact eyes, intact gut, and so forth. We're going to talk about optimization of the jet for the healing of air leaks, especially PIE, as well as obviously the prevention of all air leaks. And we want to be able to recognize, manage, and what's most importantly is avoid complications associated with the jet. So I'm going to spend a lot of time on how to avoid the number one complication, which is hyperinflation. And again, just to show you what's possible, this is a 23 and 5/7 week baby, 240 grams. So this would be the smallest survivor with first intention jet. And once these babies have stabilized their cerebral blood flow, and these very tiny babies, for us, it's usually about 14 days to make sure we're way beyond any risk. Then we will start to do skin-to-skin care even on the jet. Again, the primary indications for the jet, number one, it was pulmonary air leaks. This is /political/monetary issue because the goal was to get this approved by the FDA a long time ago in the middle 80s. And these papers showed, I'll let people mute themselves. This paper showed that the jet increases healing of PIE, the jet reduces incidence of air leaks, and the jet improves survival of neonates with pneumothorax or PIE. The more important thing, since we're no longer in the late 80s, that it's now 2026, is we really want to focus on avoidance of problems. So we've transitioned to first intention for the treatment of RDS. And there were studies in the 90s that had addressed this, and it was shown with the correct management strategy that the jet reduced the incidence of classic BPD by half in infants with RDS treated with surfactant. This is 40% down to 20%, and that was a multi-center RCT done by Martin Kessler. If you look at more recent papers, there was a paper from 2024 that was done by the Harvard team at one of their inborn hospitals, which was Brigham and Women's, and using the Iowa high-frequency jet protocol, they showed at less than or equal to 26-week gestation, if you had respiratory failure, and they designed that, they stated that in terms of RDS as an OI greater than 5, jet versus volume targeted ventilation of the 5 per kilo using a cohort trial reduced the incidence of grade 3 BPD by roughly 80%, and that was adjusted for gestational age, birth weight, and AAA gradient. What they also showed, if you were female at 26 weeks, had no lung disease, didn't really matter. And for both males and females at 27 weeks, the outcomes were similar for both the JET and the fiber kilo volume targeted ventilation. We published a paper in 2024 to go even lower because there's also a lot of concern about the efficacy of the JET at really low birth weights, and did not want to quibble about gestational ages. So we looked at all our babies less than 501, which was 92 babies from 2012 to 2022, mean gestation 23 weeks, or mean birth weight 440 grams. And we showed that the survival with first intention JET was 61% in this incredibly high risk population. As you can see, in 2024, Bond type C survival was just 27%. And then again, grade 3 BPD was only 14. Need for a trach was only 6%. Grade 3 for IVH was only 16. Importantly, ROP needing intervention was only 15%. Why is there controversy about the JET? And this all goes back to the two major RCTs of first intention JET that occurred in the surfactant therapy era. And the problem was uniquely different management strategies. So Tom Wiswell published a paper, the first paper from these trials in '96, and he showed that the JET did not reduce the incidence of BPD. Unfortunately, it clearly increased the incidence of cystic PVL, and it increased the incidence of poor overall outcome, again defined as cystic PVL, grade 4 IVH, or death with the JET. Was that a problem with the JET? No, the problem was how the JET was being managed. And the problem was a tolerance of hypocarbia, extreme hypocarbia with a mean CO2 level of 17. Now, if you have a CO2 level of 17, it doesn't matter. Oops, sorry. Maybe someone just needs to mute. I don't know. That they if you have a CO2 level of 17, it doesn't matter whether that was generated with a conventional ventilator or high frequency ventilator. It's the impact of CO2 on cerebral blood flow causing cerebral ischemia. The why they ended up with CO2 of 17, that was never their goal, was they limited the PEEP to 4 or 5 and would not let people adjust it to increase mean airway pressure. So their mean airway pressure became dependent on their peak inspiratory pressure. And thus PEEP was not adjusted to either limit tidal volume or to maintain or increase mean airway pressure, which just became dependent only on PIP. So, for example, if you were at 27/5 and your CO2 was too low, 17, and you drop from 27/5 to 20/5 in that population, suddenly you lost oxygenation and you're desatting your 100%. So they went back up on the peak pressure. So that was the problem, not allowing PEEP to be adjusted as needed to generate mean airway pressure. In contrast, when Dr. Kessler did their part of their study, published in 1997, and they looked at a group where they were allowing them to adjust the PEEP, they found that the JET did reduce the incidence of BPD by half at 36 weeks PMA, with no difference in PVL or IVH. And again, the key was an optimal mean airway pressure tidal volume strategy. Now, they were always keeping the PEEP greater or equal to 7. Again, I want people to realize this study was done when antenatal steroids were not being widely used and the surfactants were not as efficacious as the surfactants we have now. So they had no hypocarbia. The mean CO2 level was 40. And again, the PEEP was adjusted as needed when PIP was weaned to avoid excessive loss of mean airway pressure and concomitant loss of oxygenation. So it wasn't that the 5 was harmful or that the 7 is safer. It's the ability to adjust the PEEP when needed to improve mean airway pressure if you have hypocarbia. Because if you have hypocarbia, you want to drop your peak inspiratory pressure, which obviously you go low enough, it's going to drop your mean airway pressure. I think we talked about this before, which is, for the neuroprotective approach, we don't want to be struggling with, increasing PIPs and PEEPs and causing volume trauma in the DR. So we start with 50% oxygen to get across the AA gradient to improve oxygenation. We intubate right away in the 22 and 23 week population, because we know if you let 22 and 23 weekers struggle in the delivery room, and we look at the data published out of Alabama, they showed that the risk of severe IVH and death increased twofold versus not letting these 22 and 23 weekers struggle. This is very different than 24 and 25-week population. The other thing is we focus starting with a PEEP of 5. Again, the whole goal was to avoid hyperinflation, especially in this population where most of the lung is conducting airways and air trapping occurs very easily. When this was looked at, aggressive lung recruitment was looked at in RCT published by Kirpalani in 2019. The study was stopped early because the increased death in the sustained inflation group using very high, they used a PEEP of 15 in that group. Actually, I'm sorry, they used actually a PEEP of 20 for 15 seconds. So it was incredibly high pressures, which worked well in a term rabbit model, but instead in this population, it increased the death quite high. And the majority of the deaths, 11 out of 16, occurred in the smallest population at greatest risk of hyperinflation. And again, we don't need to start with the jet and the DR, but we start within 10 minutes of life. And then we give our surfactant. And of course, we don't let these kids get cold. And importantly, we make sure everyone reaches sats in the 80s by 5 minutes of life by starting on a baseline higher amount of oxygen. So we don't have to use as much aggressive resuscitation with the pressures. Okay. Sweden and Japan and us all use elective when we do intubate the 22 weekers, which would be 100% of the ones that parents wish resuscitated. We're going to intubate electively with 2.0 tubes. One of the concerns is a 2.0 tube a problem on the jet? And it's not. So we looked at 69 babies with 2.0 tubes compared to 75 babies with 2.5. Of course, 2.0 patients were more premature and smaller. The smallest 2.0 patient was 240. The smallest 2.5 patient in that study was 463. The 2.0 patients, of course, did require significantly higher jet peak pressure, 27 versus 22, to achieve a similar CO2. This is perfectly expected. This is just the physics of fluid dynamics, Puzo's law, Persuelli, depending on whether you use French or American pronunciation. We know resistance goes up to the radius of the fourth power. So to deliver the same volume with higher resistance, it just takes higher pressure to overcome that resistance. So it's about a 5 centimeter difference. And that remained constant from both day 1 and day 7. Obviously, the babies that are more premature and smaller tend to be on the vent longer. So that's why half of them were upsized. And the upsizing usually occurred around 24 to 27 days. Most of the upsizing was basically due not to air leak, because the jet doesn't care about air leaks, but eventually suctioning of the secretions became a little bit more and more difficult over time. The main thing is that there was no difficulty in maintaining effective ventilation or oxygenation with a 2.0 ET tube. The trick is you have to have a 2.5 adapter put into the 2.0 ET tube. This is very similar to when the jet first came out, and there was no 3.0 adapter when it came out, so we used to put the 3.5 into the 3.0 tube. And then you have to use a 5 French catheter because the diameter of 5 French is 1.5 millimeters, so we can get through the internal diameter of a 2.0 tube. Overall survival was 77% of patients initially intubated with 2.0 tubes, so it was not a marker of viability. So when using first intention, it's important to avoid air trapping. So a couple of things that are important. One, in the 21 to 23 week population, we start at 300 breaths per minute, which is an IE ratio of 1 to 9. The reason you have the lower rate is more time spent exhalation with the fixed IE time of 20 milliseconds, which decreases air trapping from passive elastic recoil. You don't stay at that rate. As the lung develops and more of the lung becomes gas exchanging airway versus gas conducting airway, the rate should be increased after a few weeks as the lung develops, as another way to improve oxygenation and ventilation based on postmenstrual age. So we might start at 300 and the baby's 24 and 0, 24, 1, 2, 3. And if the baby's, starting to have higher need for oxygen or ventilation, we'll start to increase the baseline rate to 360 and then readjust from there. And greater or equal to 27, we'll increase our baseline rate to 420, which basically matches what the jet was designed for a long time ago. And again, with this population, we never touch the I time because we still want to be fixed on avoiding air trapping with our E ratios, and reducing volume trauma. Now, this X-ray, oops, sorry, this X-ray here was a baby that was started on a rate of 420 instead of 300 and developed air trapping quite quickly. So our goal is to avoid air trapping causing either PIE or hyperinflation or overdistension, or if we're not air trapping, but we're too high of rate, we can end up having problems with hypocarbia. There's no need to use side breaths initially. The next thing, initial peak pressure, that's usually the easiest. It's, in the low 20s for a 2.5 tube, in the mid 20s for a 2.0 tube, again, because high resistance to flow. And then you just adjust, make sure that you can see the chest moving, you just based on CO2, knowing that tidal volume is proportional to delta P unless hyperinflated. The other, I would say the number one mistake is people starting with too much PEEP. And they're extrapolating from the studies in the early 90s to now, which is a completely 100% different population. So you have to be aggressive about avoiding hyperinflation. So we always start at 5 in the antenatal steroid and approved surfactant era. This is to avoid mechanical injury to the extreme lung from hyperinflation. So it's lung protective. But importantly, as you see this heart here, you're impeding venous return. So you have horrible cardiac output and horrible cerebral blood flow. So a neuroprotective strategy would be not to get hyperinflated. Management of oxygenation on the jet in this population is, again, directly proportional to mean air pressure unless hyperinflated. It's so important to have some concept of your If you look at this patient here, this is a baby on 34% oxygen, and the heart looks great, and I can see clearly between the ribs, and we're not hyperinflated. Obviously, if this was a patient after surfactant, the ribs are not, the area in between the ribs is not clear enough, so you would want to go up some on your mean area pressure. And obviously, if you have this picture, you've got to go down aggressively on your mean area pressure before you pass away from lack of cardiac output. That type of X-ray, you end up with hypercarbia as well as hypoxia. So you want to avoid 9 to 10 rib expansion. So you have to follow chest X-rays closely to avoid hyperinflation. So two things: you have to get at least roughly 3 X-rays a day, every 8 hours for the first 3 to 4 days. Because if you wait until you see impact of being hyperinflated, which is increase in CO2, increase in PVR, decreased cardiac output, it's too late. We also want to remember that mean area pressure is primarily generated by the jet PIP, conventional PEEP, and jet rate. So the keys are, if you're hypoxic from inadequate aeration, let's say this one here, with a good CO2, let's say 50, let's increase both PIP and PEEP by the same amount, 1 and 1. Or if we're on 100% oxygen, we might go up 2 or 2, but usually we tend to go 1 and 1 and wait and watch and see what happens. And we'll keep the delta P constant, which is why we do both PIP and PEEP 1 and 1, so the tidal volume doesn't change. If we're oxygenating well with acceptable CO2 and overinflated, now it wouldn't be, wouldn't be this X-ray, but let's say this X-ray was more like 8 to 9 in that lucent, we would decrease PIP and PEEP by the same amount. Or if these babies get down to 21% oxygen, you're probably going to be transiently overinflated, so we would electively go down. Hypoxic with hypercarbia, it sounds like a bad situation. It could be if your X-ray looks like this, but if your X-ray looks like that, you increase PIP, which increase both tidal volume and mean area pressure. The mistakes that happen are people know the baby's hypoxic and hypercarbic, and they don't get an X-ray. So you can't, without the X-ray, you don't know if you're here or here. Patchy atelectasis, we'll talk about side breaths. And we talked about increasing the jet rate to help to optimize ventilation oxygenation as the lung development progresses from the canalicular saccular stage to more saccular and less canalicular. Ventilation perfusion mismatch improves with optimal PEEP. I mean, I do give a starting number, but after that, sometimes our PEEP might go down to 3 or 4. Sometimes we might, toward the hospitalization, be close to 10. So this is optimal PEEP means that the alveolus is neither hyperinflated nor atelectatic and collapsed. So here's the optimal look of that alveolus. We have deoxygenated blood goes in, picks up oxygen, goes to the capillaries and the pulmonary veins and gets pumped around. That's how we'd like all the lungs to look like. That's like a nice, person having elective surgery for the most part. The neonatologists are excellent with these. These are alveoli that are completely atelectatic for various reasons, most likely surfactant deficiency disease or congenital pneumonia. In these cases, blue blood goes in, blue blood comes out. So we're not improving anything, and whatever oxygenated blood is getting mismatched and diluted out by the deoxygenated blood coming through the pulmonary veins. Neonatologists were all fantastic dealing with this picture. This picture here is the main problem that we have trouble detecting. We can't get pulmonary capillary wedge pressures, is this hyperinflated state. So what happens in this case, one, you have very high pulmonary vascular resistance, so it's hard to get blood in, and people will measure and say your pulmonary vascular resistance is high and start treating it as a pulmonary arterial vasoconstriction episode, but it's not. It's pulmonary venous hypertension on this side. So it's so hyperinflated, you have trouble getting blood in, but you also have the compression of the pulmonary capillaries and veins, so it's hard to get blood out. It's also not due to left ventricular failure. So optimizing left ventricle is not going to help with this situation. You have to get the ventilator settings down. Okay, I'm going to take a quick breath to see if there's a few questions, and I'm going to re-talk about this problem of hyperinflation. So Allison, I'll let you know if there's no questions. I'd be glad to keep going until I get to the cases.
I don't see any questions for
Okay,
right now,
perfect.
unless, yeah,
Perfect.
you're good.
Nope, I want to keep going. Let's keep going. Let's keep going. All right. So I want to focus on this, which is the impact, not just of air leaks, but the impact of also of hyperinflation of pulmonary vascular resistance. So everything focuses around the physiology of this graph here. Lung volume is on the x-axis, pulmonary vascular resistance is on the y-axis. So let's start with the easy part, which is alveolar compression from external forces, such as pneumothorax, or PIE, which is outside the lung, or internal forces, atelectasis, primarily surfactant deficiency or surfactant dysfunction, or filled with, pus from pneumonia. This collapse will compress your pulmonary capillaries and veins and increase your PVR, which worsens oxygenation and ventilation perfusion mismatch. And external compression, most importantly, decreases preload, worsening cardiac output and oxygen delivery. And this is what we look on scanning electron microscope, and you can see your pulmonary capillaries and venules being compressed. This is just a good example of surfactant deficiency causing the same problem. So we really understand this well for the most part. This is the area that we have trouble with. And this is, we're now, rather than having the lung at residual volume, we're at total lung capacity. So the lung is getting hyperinflated. And the hyperinflation is, again, not inside the mesenchyme. This isn't PIE. Obviously, it's not pneumothorax, which is easy, but it's internal. It's internal hyperinflation. The type 1 cells haven't ruptured yet. The bronchoepithelium haven't ruptured yet. So we're getting it very hyperinflated. As you can see here, this then compresses the heart. And as you see here, so pulmonary vascular resistance is high and you're hyperinflated. And here your alveoli hyperinflated, and basically you're compressing all the capillaries and venules. So this intraalveolar overdistension, hyperinflation, overinflation, also increases pulmonary vascular resistance, compresses pulmonary veins, so you have pulmonary venous hypertension, worsens oxygenation, worsens VQ mismatch. Importantly, one way to detect it is it worsens ventilation. So it limits passive elastic recoil. So if there are changes in ventilation, you have to think, is it due to progressive dysfunction of the surfactant, or we've got air trapping, which is the silent killer. And just a small change in rate will start the air trapping, and over time it builds up. So even if you're only air trapping 0.001%, you still can end up dead by 18 hours of life. It worsens oxygen delivery by decreasing cardiac output, as you can see from that heart, from inadequate preload, just barely any preload there, from decreased venous return. So again, this is the silent killer in this population, and you have to aggressively look for it because you can't find what you're not looking for. Now let's go where we should be, which we want to be at FRC, but not in this population, because these aren't term babies with 50 million of VLI. These are 22 weekers with 500,000 of velar sacs. So if we get hyperinflated, all we're doing on the X-ray is that we're inflating the conducting airways and not the 500,000 of velar sacs. So we want to operate a little bit atelectatic, so a little bit below perfect FRC, right around here. So, here's our VLI, and we're not collapsed, we're not hyperinflated. We can actually see capillaries and veins. And again, here's sort of an X-ray that for a very premature baby would be acceptable. We're 9 ribs, we have some haziness. The heart is well expanded. This, again, the baby's on 34% oxygen. So trying to push this to look clear, which may be fine at 28, 29, 30, so forth and older, would just end up resulting in complications of hyperinflation. So it's unrealistic to expect someone to really be on room air with normal PO2s in this population without incurring potential lung injury. So this is a good table to keep around. So this management of ventilation. We know ventilation is tidal volume squared times jet rate. The tidal volume is the delta P, PIP minus PEEP. Increase tidal volume to improve ventilation. You just increase delta P, increase the jet PIP for the most part. Or you can decrease tidal volume to decrease ventilation by decreasing delta P, by decreasing the jet PIP. That's the most straightforward way to look at it. And this table just gives some guidance. I found that over time, that people were just reluctant to make more aggressive changes. So people would spend too much time with CO2s in the teens or 20s or low 30s versus if they're that low, they should be making much bigger changes. And so that's why this table's here. So again, we talked about hypocarbia and borderline oxygenation, which is the worst case. You decrease delta P. We want to get the normal CO2 as quick as possible. So we decrease delta P by decreasing peak inspiratory pressure, but increase PEEP as needed to keep mean area pressure appropriate to avoid atelectasis leading to loss of oxygenation. So this type of situation, when both things are bad, you're going to have to you have 5 minutes to get that cerebral blood flow back to normal. So let's get that CO2 going up. Let's be aggressive with that. And so you may end up going down by 2 a pip, 3 a pip, 4 a pip. And since it's borderline oxygenation, we'll also go up 1 on PEEP, and that will also greatly reduce our delta P to get our tidal volume down, as well as increase our mean area pressure, because a centimeter of PEEP is, depending on what rate you are, could be the equivalent of anywhere from 6 to 9 pressure changes by 1 on a PIP. Once you have the CO2 that you like, then it's very easy to start to increase the PIP and the PEEP by the same amount. Now, sometimes if your hypocarbia is barely hypocarbic, 34, you could and you're not oxygenated, you can increase PEEP alone, which will decrease tidal volume and increase mean air pressure and improve oxygenation. I think we talked about those other ones. So we always use the jet with the fixed I time. We know that exhalation on the jet is passive from elastic recoil. We cannot inhibit that elastic recoil. It's very dependent on kind of how much lung is primarily just the conducting airways, and how much the lung is now getting more saccular and eventually when you get mature enough, actually a VLI. And so knowing that the capacity for the lung to be able to have that recoil based on getting away from the canalicular stage, these are our initial jet rate for first intention, 300 for less than 24, 360, 24 to 26, and 420 for greater than 27. These are the IE ratios. It also just has to do with the physics of actually the size of the distal terminal bronchioles. Again, the physics hurts and fluid dynamics hurts. So a small decrease in the size of that airway increases resistance. A small decrease in radius increases resistance by the radius of the fourth power. So the purpose of the lower initial rates is to have increased IE ratio to avoid air trapping, hyperinflation, overdistension, as well as hypocarbia. We also know resistance is much higher during exhalation than inspiration, which is how you get air trapping in the first place. And then as lung development progresses, we can readapt to that new situation. The good thing is this chart also works for post-menstrual age. So many times people will talk about, well, I have this 22-weeker and the baby's 7 weeks old or 6 weeks old, and they're on a rate of 300, but their pressures are 42/15. I was like, well, first of all, you shouldn't still be on a rate of 300 because functionally that baby's a 28-weeker, should really be on a rate of 420. And you probably didn't need to be as aggressive with those pressure changes. And as the PEEP gets too high, now you start going up in your PIP because you're having more problems with passive elastic recoil, and you just sort of get yourself into kind of a difficult spiral there. This is a table that works well for these basic management strategies, and it covers everything I went over before. Now, I am going now to talk about sigh breaths. And sigh breaths are one of the, so talk about things that are misunderstood. Number one is PEEP, and number two is rate, and number three is not understanding the function of sigh breaths. So sigh breaths are not designed for recruitment of diffuse atelectasis, whether that's due to pneumonia and surfactant dysfunction or primary surfactant deficiency. The sigh breaths are designed for recruitment of patchy atelectasis. If you need to recruit diffusely, you should be going up both on PIP and PEEP, as we talked about, to increase mean area pressure. So when you start first intention, we do not start with any sigh breaths at all. Now, as the baby gets healthier and it's getting stronger and we're weaning the ventilator, as both lung disease gets not as severe and the baby is getting stronger as it's starting to use its respiratory musculature, they'll start to develop atelectasis because there's gravity on this planet on Earth, and we have dependent atelectasis because we will reposition the babies to avoid pressure-induced injury and so forth. So when we're starting to see atelectasis, usually it always tends to start on the right side of the lung, sometimes right upper lobe, sometimes the entire right side. Then we will be initiating the sigh breaths. Arbitrarily, we use a rate of 4. Dr. Kessler uses a rate of 3. There's some randomness. Some people use 5, but we've used 4 for a long time, and it's arbitrary, but it seems like it works very effectively. So it's used for alveolar recruitment for patchy or wandering atelectasis. And once you start it, you continue, because the reason for this wandering atelectasis, which is dependent atelectasis and repositioning, as well as very weak musculature and very weak rib cage, it doesn't go, it will come right back. So there are a lot of places that are given the wrong information, and they treat these babies like adults, and they think, okay, once it's open, it will stay open. No, it will just collapse back down again. And Dr. Kessler, same thing. We both say, once you start them, you just leave them on. These breaths are not designed to remove CO2. They're basically just delivering a little bit more than 3 mLs per kilo, because you have to exceed the conducting airways in order to get them this volume into the gas exchanging airways, for example, the alveolar sacs in this population. Now, obviously, if you develop PIE or pneumothorax, you're going to get rid of them. So, we tend to use a setting of 0.4, kind of twice the normal inspiratory time of these babies, which tends to be around 150 to 200 milliseconds. And if there's if we're talking babies 6 weeks later, we might talk about going up to 0.5 as they get more toward 28 to 30 weeks. The peak pressure tends to be anywhere from 6, 8, 10 above. The PIP, and the PIP is the PEEP plus 6, 8, or 10. And what you want to see is some chest wall movement. It does no good to give a sigh breath if you don't see the chest wall. It has to move a little. You don't want to be able to see it from a mile away, but it needs to be moving to reassure yourself that you're actually exceeding the conducting airway. And again, like we'll start them and we'll leave them on. And there's too many places that this question's the same. We start them, atelectasis goes away, we stop, it comes back. Start goes away, stop comes back. So it's, what do we do? I'm like, stopping them. So that's pretty straightforward. I think this thing, the next thing is this, which is quite a little bit more complicated, which is for these intermittent hypoxemic episodes. And these are central apnea type spells, which present with significant desaturations, less than 70 to 80, when spontaneous respiratory rate drops below 15 to 20. So as you notice on this graph here, when the baby's spontaneous, and these are babies who've been weaning a lot. So these are babies not the first day. These are like, weeks into the course as you've been able to wean a lot of the jet support. So you're getting dependent on the baby's own spontaneous breathing, which is good because the more the babies breathe, the more the lung develops, the stronger the airways get. You're basically training the baby to be ready to succeed extubation. So you can see when the baby's breathing, 30s to 60s, and so far 40s to 60s, everything the stats are here are really good. Now the baby drops here for a few minutes just below rate of 22, and you can see the oxygen starts to plummet. Why is it plummeting? It's plummeting because there's no residual volume in these babies. So if they're not breathing, at least, for the most part, 18 to 22 times a minute, they're going to desat. If you're on a conventional ventilator, you know this because the nurse will say, the baby, you have this baby's doing great on a rate of 25, you drop to 20, the baby now starts to desat, and the nurse will say the baby's riding the ventilator. They're just breathing with the ventilator, and whatever oxygen in there, within 3 seconds, it's all diffused across because the residual volume is non-existent at these gestations. An adult, your residual volume will keep you alive with 350 million alveoli for 5 minutes, which is why adults really don't need mouth-to-mouth for the most part. You're really trying to get an AED for them and do chest compressions. These babies, you need to have a ability to get oxygen in. And so if these cases, when we see this behavior, this was happening here at a rate of 4. For this baby, I think we had to go to a rate of 10. And then when this baby slowed its breathing down, you can see all these, like here and here, we never, barely went below 80. So the problem was resolved. So again, these aren't for gas exchange. We're not trying to remove CO2. And most people, if you use NIV-NAVA, you're really comfortable with the idea. That's why NIV-NAVA, when it was an apnea delay of 5 seconds, these kids failed it all the time because of apnea. You weren't kicking in the backup rate soon enough. And when the company lowered it to 2 or 3 seconds, which is rates under 20, suddenly it was working fantastic. The next thing, the only other issue you need CYBRES for is if you have this alarm, it's called cannot meet PIP or loss of PIP. It occurs when you're on really low vent settings for a very tiny baby, and the machine will shut off because the baby can suck up all the bias flow from the jet at that point, and it will alarm that you're even though you may have ordered a PIP of 15, it can't get there. So sometimes the CYBRES are needed to increase bias flow on low jet settings. This occurs most frequently if you're using a servo, which has a bias flow of only 0.5 liter per minute as your system to generate your PEEP. It doesn't really occur. We use a very primitive thing, a cross vent 2I+. So we set the background flow rate at 10 to 12 liters per minute, so we don't see this problem. The Draeger has a 5 liter background rate, so that's also less common on that. I think Hudson's have like a 2 liter, but the major one that has the most problem, obviously, is using a servo to provide the background. So it's important to know what device you have, because then what happens, people will say, look, we have to give up because the jet's alarming all the time. We try to lower the vent settings. And again, that's just a function of the bias flow. This is to show the point, this hysteresis, as to why if you have focal atelectasis, you don't need to hyperinflate the rest of the lung to maintain it. So, the whole idea is, obviously we're somewhere in between normal and RDS lungs, but the point is the same. Ideally, we're closer to normal because we've treated them with surfactant. Is it takes a lot of pressure to inflate. So this would be the PIP above the PEEP, but it doesn't take that much. Once it's open, it's easy to maintain that until you reposition the kid 4 hours later, for example. So, there are a lot of people that get too aggressive with the side breaths and also go, oh, we have atelectasis. We need to increase both PIP and PEEP, which is wrong because you're going to get hyperinflated the rest of the lung. All you have to do is increase your PIP a little bit to get up on the inflation part of the hysteresis curve. And once it's open, it will stay open. Okay, pneumothorax or PIE, you want to bring your rates down. So whatever rate you're on, just get it much lower. So when we treat PIE, which would be primarily from outside places, we'll get our rate down to 240, which is basically a 1:12 IE ratio, and you get rid of your side rate. Okay, I'm going to stop here again before I start on some cases and more stuff. So any other quick questions, or I can keep going?
There are questions. One question is, when increasing your jet rate, how do you avoid air trapping and hyperinflation with the other settings?
Okay, so I guess the question is, we only increase the jet rate if we're at a developmental stage where that rate's appropriate based on the airways. We would never increase the jet rate on someone who, someone who's in the first, that gestational age. So, let's say we have a 21, 22, 23 week at a rate of 300. That rate is never increased. And the I time is never increased. And we manage that with, we manage ventilation and oxygenation at a rate of 300, which are very small tidal volumes. If you think about tidal volume squared to have the same normal CO2, those are incredibly low tidal volumes compared to the 5 ml per kilo rate you might use with someone on a rate of 40. So it's really not a problem. I mean, you shouldn't be, I guess the question is, you shouldn't be increasing that rate if the issue is hyperinflation. And so I think there are people that just, you cannot get hyperinflated. Now, let's say, if I'm at a rate of 240, usually by the time the baby's better, they're ready to go back to a baseline rate of 300. And so we only increase the rate on babies, like I said, that may be now post-menstrual age greater than 24 weeks. Sometimes we don't. If that baby at a rate of 300 is on 28 to 34% oxygen, we'll leave them alone. If that baby is starting to white out, then we'll increase the rate. And we're not really concerned about air trapping because we're increasing the rate because they have diffuse atelectasis and increased vent requirement and increased oxygenation requirement. So we only increase the rate where we want to recruit more lung tissue.
Okay, and then thank you. So that was kind of two questions in one. And then real quick, any evidence or research that supports the idea of volume targeted ventilation is just as lung protective as the jet in these babies?
So, if you look at this, I would say the answer is probably not, because it's really not. So let's just look at, if you look in Sweden, they like to start with conventional. They'll start with a PEEP of 4.5 or 5, and they'll use volume targeted ventilation, also of kind of this, with a 4.5 to 5 per kilo. Will never exceed 5 per kilo, but their pressure limit is at 22, because they found if you expose a 22 weeker and tolerate a pressure above 22, you rapidly will have problems and get into volume trauma. And so if they find that it's occurring, then they will immediately go to high frequency mode. Now they don't, that's not with the jet, but using the Draeger, volume guarantee high frequency. So, and then I would go, if we go to the paper was published out of Brigham and Women's in 2024 in Frontiers, what they showed, they looked at, the babies managed with 5 per kilo volume targeted ventilation in this population, and again compared it to the jet, and the jet was superior until you got to 27 weeks, and then it didn't make any difference. So 5 per kilo, but again, you have to, the whole problem with, again, volume targeted ventilation, you have to have very strict limits on the pressure shear force that you allow them to be exposed to, because there's a huge amount of flow and a huge amount of shearing. So, I would say, based on the literature that's out there, that at 27 weeks, either one is fine for the most part. At 26 weeks with no lung disease, it's fine. Anyone with no lung disease, which I'm going to show you in a second, it's pretty fine. But if you have immature lungs and you're less than 26 weeks with lung disease, it's the best outcome, I would say, based on what is out there, would be using jet in an optimal way.
Okay,
So
thank you.
I might go and start with this case, because I think I'm like only
Okay.
30% of the way through the talk, but we'll keep going. So this is a good example. Now, this is rescue. This is a patient a couple hundred miles away from Iowa City, and this was using rescue jet for an outborn patient with PIE. So the first thing you notice, 24-week male, twin infant, who developed severe PIE on day of life 3 on volume guarantee, conventional ventilation, 5 mLs, 5 cc's per kilo. His twin sister, same vent, had no PIE at all on the same 5 per kilo. Well, why is that? Well, the sister only needed pressures in the high teens to deliver that volume, because females are 2 weeks more advanced in terms of lung development than males. For him to receive that same 5 per kilo, he suffered a huge amount of shear force, because they did not have any limit on the peak pressure. It wasn't set at 24, it was set at 35. And so he ended up having tremendous shear force, developing horrible PIE, end-stage PIE. So his PIE progressed with his left lung hyper expanded to 11 ribs with contralateral right-sided atelectasis and severe respiratory failure. They tried to rescue with the oscillator, which just made things vastly worse, and then came to us on 100% oxygen on day of life 10 for rescue with the jet. The team did their correct approach, which was get to the lowest possible rate, which is the longest IU ratio. So they rapidly got him down to a rate of 240 and get the pressures way down. So the PI resolved after 48 hours on the jet with a rate of 240, getting his pressures down as low as 31/4, have no side breaths, and their standard I time of 0.02 seconds. So by daylight 12, after 48 hours on the jet, he was on 34% oxygen, great gas 730, 59 plus 2, so that's 87%. So they did the correct thing, which was, get him on a very low rate of 240, because this was end stage. Now, let's talk about the rest of the story. This is 10 days with this heart, basically like this. So unfortunately, when he got the screening head ultrasound, it showed cystic PVL, because you can tell the cardiac output is horrible when this heart is like this. So did not have the same neurodevelopment outcome of his sister. So as we talked about, number one complication is hyperinflation. Secretions, we do inline suctioning. We don't really feel it's that big of a deal. And actually, we don't even do really that much routine. The nurses do it at the beginning of the shift, and maybe if they think secretions are a problem, but no routine suctioning. People miss hypotension all the time in the beginning because they don't screen actively. Air leaks will occur, primarily PIE, again, if you don't detect it soon enough. And then hypocarbia if you're not monitoring your CO2 and weaning the ventilator correctly. Other things. Okay, I'm sorry. Want to make sure I went to those other cases. Monitoring, we don't use the servo pressure other than for troubleshooting. We don't stress about it too much. In the old days, auto PEEP was, people thought about it all the time. We don't really think about it anymore, because we set the PEEP based on the measured value on the jet. So I want to know, what is the end pressure as interpreted by the jet's monitoring, not by the conventional ventilator put in. And so we adjust the PEEP based on the radiograph, so it's not an issue with the lower rates used, allowing adequate time for elastic recoil. So I think I've seen a lot of people get into trouble because they say, well, we're using a PEEP of 5, but they're measuring it on their machine, while the baby's actually seeing 6.5 or 6. So we really want it, this is all based on what the baby's seeing. Chest x-ray frequency. I feel if you give surfactant, sometime 2 to 4 hours after a dose of surfactant, you should double check, unless that's X-rays coming about at a kind of the Q8 hour phase for the first 3 to 4 days. So we have morning X-ray, we'll do checkout X-ray, and then sort of kind of a bedtime X-ray. And again, we're targeting 8 to 9 ribs, always balancing oxygen exposure over distension. So it's okay to be 26 to 34%. The goal is not to force everyone to 21, because that is not normal at this gestation, and you end up with air trapping and passing away. We do follow CO2 closely when cerebral blood flow is most sensitive to CO2 levels, which is basically the first 3 days to a week, depending on what study you look at. So we'll target kind of, 40s and 50s the first 3 days, and then maybe 45 to high 50s the next 4 days. Yeah, we will. And if we have a line, we might check gas every 3 hours. If we don't have a line, we'll still do a cap gas 12 times till we get through the first 72 hours, because I don't want to go 12 hours with a CO2 of either 17 or 77. We've never been able to get transcutaneous CO2 monitoring to work, but if you have it work, it's great. The other thing is there's no need for routine sedation with the jet. We basically never sedate these babies. We want them spontaneously breathing to build up their intercostal, subcostal, supraclavicular, abdominal muscular diaphragm strength, as well as help with lung development and recruitment. Common pitfalls: people start with too much PEEP, hyperinflated. People start with too much rate in this population, with inadequate IU ratio, getting hyperinflation. Overweening the PIP for hypocarbia without adjusting the PEEP, that would have been the Wiswell trial. So increase the PEEP to decrease the delta P to decrease the tidal volume by maintaining appropriate mean area pressure. Another problem is inadequate sigh breath PIP to treat watering atelectasis, or inadequate sigh rate to treat desaturation spells. So if it's just recruitment, 3 to 4. If it's for spells where you need to actually get oxygen in, then you might need rates of 10 or 12. And then people forgetting to increase the jet rate as the lung goes from the canalicular to the saccular phase after approximately every 2 to 4 weeks of development. Extubation criteria in this population, because we're talking about tiny on average, and we published papers that have shown that their mean area pressure tends to basically be, between, actually in reality, 10 to 11. So people are kind of following the instructions from long ago. But we don't push anyone off, because early failure causes numerous problems. As we talked in the support trial, if you fail in the first 2 weeks, less than 26 weeks, death went up from 6% to 28%, as well as severe IVH. And if you look at the Apex cohort trials, early failure in the first week of life had a greater risk of death also from grade 4 IVH, pulmonary hemorrhage, respiratory failure, and NEC. Again, these are babies primarily less than 26 weeks. And interestingly, they didn't even include 22 weekers in their study, and they had 100% failure rate in the first week for 23 weekers. And we're strong believers you go to non-invasive ventilation and show that they're doing well. And once they're stable with not having spells that need the non-invasive ventilation, then we'll go to CPAP. I think it's very hard if you go straight to CPAP to rescue them. All right, now I want to go through some more cases, because I think these are a lot more illuminating. So this was a baby. I've already given you the problem, which is hyperinflation that occurred. And this is, a 22-weeker, 367 grams, got surfactant on admission to the NICU. This is the first film. And this film was on a PEEP of 7, so not following protocols, rated 240. And I think their thinking was, that if they use the rate of 240, it will avoid the hyperinflation by having an IU ratio of 1 to 11.5, 1 to 12. But PEEP is always there. And PEEP is the most harmful thing in this population. And they're doing great at 30% oxygen. Now, this X-ray is hyperinflated. And that's not been they're not recognizing it completely, but the diaphragm is flat. It's completely flat. And so it's not impacting the heart yet. So, and you've already recruited, what you can do, because you're already down to 30% oxygen. So like I said, if you don't really take everything into account, trouble is going to slowly come up. So now at 3 hours of life, the baby went down to 26% oxygen. So they decreased PEEP to 6 because they said, okay, we're probably recruiting too aggressively and getting too hyperinflated. They didn't get an X-ray at 3 hours. They did get one 6 hours later when he was 8 hours old. And oxygen had gone from 26% to 40%. So they now got the X-ray at 8 hours of age. Now, this film is lordotic, but this film is very hyperinflated. I mean, basically now you're just seeing the conducting airways. And if you switch it from lordotic, you can start to see the posterior diaphragm diving down to 12 ribs and beyond. So knowing this, they've got to be aggressive with the PEEP and so forth. So they didn't make any changes on this X-ray. They just, because they figured 40%, that's not that bad, but not realizing why was the oxygen going up? There's not worse atelectasis, right? There's not worse. The problem is the PVR resistance is way up because of pulmonary venous hypertension. So, thinking, and if you think the only problem in a preemie is surfactant deficiency, that's just not true. And so I can see how their thinking was going. So that's 8 hours old. So as the hours tick by, the baby completely lost the ability to ventilate. So now has a severe respiratory acidosis. So an X-ray was not obtained to try to figure out what's going on. They just increased the peak pressure, quite a lot. As they kept going up on the peak pressure, the baby at 11 hours lost oxygenation. So they got echoes showing high PVR and started vasoactive drugs. Still had not gotten an X-ray yet. And obviously, they also decided to increase the PEEP again without getting an X-ray. So they now went from 6 and then they went up to 8 with no X-ray to guide them and an already hyperinflated X-ray. So 2 hours later, they did finally get an X-ray as this baby's deteriorating, and this is the X-ray. So at this point, everything is completely flattened, what's left of the diaphragm, and there is basically no blood flow going to out of the heart. This is at 13 hours of life. The baby rested and started coding and then passed away at 18 hours of life. And again, they kept wondering, well, the baby was doing so well here, what happened? Everything, all the gas was great. So you have to think if both oxygenation and ventilation are failing, the first thing you have to think about in this tiny population, since most of this lung is just conducting airway and is very easy to get hyperinflated, is to get an X-ray and look for it and prevent it from happening. So this was quite an important concept. And again, okay, here gas is okay, 2 to 3 hours and completely and dead at 18 hours. It was so hyperinflated. They were telling me they can look at this X-ray because you can see now, this heart's happy, but the lungs are hyperinflated, but it's not got to the end stage of pathology yet. And this heart is quite compressed. And they told me every time they would draw blood from the UAC, the baby would arrest because there no longer was enough blood to be on the Starling curve. So there was no coronary perfusion. Okay, so that baby passed away. Here's another 22-weeker, under 400 grams, 22 and 2/7 weeks. Let's just start at 6 days of life. The baby's on 60% oxygen with horrible PIE. You can see the PIE is 4-quadrant. You can see this heart is too well defined, so it's quite compressed from the external PIE. Again, PIE is not hyperinflated alveolar sacs. This is inside the mesenchyma of the lung. There's a lot of confusion between PIE and hyperinflated lungs. The settings in this 22-weeker, about only 6 days of life, were 36/8, rate of 480, side breath 16/8, and rate of 8. None of this is good. And part of the issue is This chest X-ray, like I said, is 60% oxygen to 6 days of life on the above settings. So the first thing is we want to prevent this. My whole point of teaching is to say, let's just prevent this problem. This baby should have been started on a rate of 300. Should not have started at a PEEP of 8. Should have started on a PEEP of 5. There are no need for side breaths in the beginning. So what they do, and when they did nothing. So no changes were made at this time, and they didn't make changes on day 7, day 8, day 9. So now we're day 10. So here we're on day 10, exact same settings, but now we're going to talk about treatment. So this is when, anyway, the other one was a mortality conference. This one, we talked in real time once it got to day 10. So they took a film on day of life 10, 100%. Now they're on 100% oxygen. So here's 60. Now we're on 100% oxygen, and I got a text. And this is the film. So again, this film is very upsetting because, one, look how compressed the heart is. So I know cardiac output's been bad. This side has all the PIE, and it's now pushed the lung, over to the contralateral side, and now we got all this atelectasis. So this will never get better unless we get all this areas of atelectasis, and this is my assumption was this probably due to the surfactant dysfunction, because actually we know these free radicals will also start to disrupt this surfactant. So the only way to get this better, was to get this open. And so we have right PIE and left atelectasis. So the plan was to give a repeat surfactant course. And I had them repeat the surfactant. With CuraSurf, you can do this with the half dose. It won't get better in 5 minutes. This is not initial surfactant. It has to be bagged in for at least 5 minutes. The jet is not designed to allow surfactant to make it through 3 mL per kilo conducting airways. And within 24 hours, once that side got open, they got down to 65% oxygen. Now, they wanted to argue a lot, so at least they did some things. So they were willing to drop the jet rate to 420 and the size to 4, but they should have really done everything that was recommended. So now the same baby, let's talk about new BPD, which is arrest of lung developmental stage. So it was 22 weeks. Now it's 28 weeks, so 6 weeks old. And the PIE is worsened, and the lungs are hyperinflated, and the pressures are way up now, 34 or 12. And the rate's 360, which it's okay. Is on a psi rate of 8, not really good, okay. Back to 100% oxygen, and they have echo evidence of high PPR index, so there's pulmonary hypertension, and they've given postnatal steroids and inhaled NO. Everything is failing. It's over. And this is the X-ray that was sent. So this is a very unhappy film in a 6-week-old. The heart is extremely compressed. You have the PIE is so bad now that it is causing what little lung tissue that's there is collapsed down into these atelectatic strands. Now, 18 to 24 hours later, instead of being on 100% oxygen with sats in the 70s, we got them to 75% oxygen with saturations in the 90s. So what did we do that make this baby better in 18 to 24 hours? Now, here's the X-ray here. Not hyperinflated anymore. PIE is under control. The heart is not as compressed here, and everyone's happier. Now we can work on, having things get better. So this was both jet plan and a lot of things. So the first thing is get the PEEP down. The PEEP is the killer in this case. So here's PEEP of 12. And now they're not ventilating and not oxygenating, but you're not oxygenating, not because of mean area pressure. You're not oxygenating because your PVR is high because of pulmonary venous hypertension. So this time I said, you have to do everything that we're talking about. So they dropped the PEEP. I said, drop the PEEP by 4. Just have to do it. 34/8. Get rid of the side breaths. I don't need the size to make the PIE worse. We need to get rid of it. In this case, the baby's own breathing is not helping. So let's go ahead and muscle relax the baby. Let's remove that baby's, we don't want any help from this baby. Plus, once you're muscle relaxed, if you think about ECMO, one of the things is if you're going to have to be able to oxygenate in a situation, you want to reduce the oxygen requirement. So oxygen delivery, oxygen expenditure, let's reduce oxygen expenditure and make sure that mixed venous set is delivering adequate oxygen. So you must relax. And then the big thing is everyone has to change their mindset in this baby transiently to allow this baby to survive. We have to transiently tolerate lower saturations, 60s and 70s, and you just go into your newborn cyanotic congenital heart disease mode. You got a newborn with one of the 5 T's with cyanotic congenital heart disease. You don't freak out if the sats are 65, 60s and low 70s. And I said, you're going to have to hold for about 12 to 18 hours because you have to first collapse the PIE. The PIE is where all the air is going. So in order to get this open, we've got to collapse all this PIE it's actually both sides now, down. And it's very easy for the air to keep going into the mesenchyme. So we have to lower to the PIE collapses. Once that happens, once that resistance goes up, so the airflow is not going through the tear in the terminal bronchial, but actually can now focus on getting those alveoli open. And as you collapse the PIE, then the alveolar sacs will begin to open. If you don't tolerate going under this pressure, it just ends up passing away. Now, I didn't include the picture of the baby's home now, and he actually looks really good. At some point, I'll add his picture. So you can, you have to think about sometimes you have to go to an extreme temporarily to be able to get things better. Okay, so easy things, those are the 2 hardest ones. The easy things are, instead of, new BPD, here's old classic BPD, alveolar septal fibrosis at the sacral stage, was pulmonary hypoplasia at 24, now is 5 weeks old. At 29 weeks, there's the old school x-ray, 735, 60, sets 84 and 100% oxygen, no PDA, no pulmonary hypertension. So again, mainly has, some areas of hyperinflations and areas of fibrosis, very high jet settings, 3709, 360, 19 rate of 4. What can we do to optimize the ventilator? So one, the jet rate for this baby is actually too low based on where the lung development now is. So we have plenty of alveolar sacs to open. We can take benefit of a higher rate, and there's no rush to get this air out. We want to baseline raise the mean area pressure using rate. And so this baby needed to be rate of 480, which is 1 to 5. The side breaths were really inadequate, 19/9 and a rate of 4 and I time 0.4. So instead of 19, let's push it up to 22, 23, 24, and let's bring the I time for 0.5. And maybe instead of rate of 4, let's do 5 or 6 to work on, more aggressive recruitment of all this lactatic area. And then we obviously the I time also to 0.5 again. This is really heterogeneous lung disease. And overall, we're 100%. So there's still plenty of recruitment. There's no really hyperinflation. The heart looks good in terms of filling. It's more this atelectasis everywhere, a lot of fibrosis. So let's just increase the mean area pressure. Instead of 37/9, let's go gently to 38/10. But I would not have any problem if someone said, we're operating the jet close to the PIPs in the 40s, and that's usually when I think about maybe this baby should be an oscillator. But the jet settings to me weren't, I usually think about it when we're in the mid 40s. So failing, if the ventilation's inadequate despite peak pressure over 45 and oxygen inadequate on FI2 greater than 75, and you're at 9 to 10, but you still have diffuse whiteout, usually due to increased body wall edema. These are kids that perfid outside of hospitals come to you a couple days later with capillary leak syndrome. and the oscillator just doesn't have enough.
You're muted. Dr. Klein, you're muted. Still can't hear you.
Okay, you can hear me now?
Yes.
All right, sorry. I think I started getting too excited and hitting everything. Okay, let's. Okay, let me. Okay, and you can hear me, right? Just double check again.
Yes.
Okay, sorry. Try not to hit I think I was hitting things. So the JET time is very controversial. I think about it if you're trying to do a diaphragmatic hernia, but it's not really appropriate for this population. And the other thing is the JET, if you have really no lung disease, the JET is really not designed for very frequent desaturation spells. And so patients with minimal lung disease, and the reason they're on high oxygen is that the nurses are turning them up constantly because the baby's constantly desatting, but the baseline X-ray looks pretty good. Then we would say let's go to volume targeted ventilation with a fixed rate to help them with the apnea. So we will transition rarely, but it does occur to conventional ventilation for central apnea. Limits the viability with first intention JET. I think we've done it very successfully down to 240 grams. And then we did a paper recently with babies that are 21 weeks that have been all discharged home, with the most premature one being 24 and 0. So with first intention JET, this is an example of a male soon after birth. On first intention, high frequency. Again, the key is not getting hyperinflated. So this was 300 in a PEEP of 5, and this is him going home on nasal cannula. The one thing with 21 weekers, they often will miss because they still need a lot of positive pressure for lung growth. So they often can miss the perfect time to learn oral feed. So he does have an NG tube there. And this is him at his 1-year-old birthday party, but for prematurity, he was just basically 7 months old. So when we think about high frequency, the RCT is ideal for evaluating things like drugs, as randomization limits further medical input. Is far less effective in testing technologies where the physician controls the way in which the technology is applied. This tactical variability has plagued and will continue to plague the evaluation of new ventilator strategies. It's now clear that we were testing the driver, not the machine, and that education was the only solution, which is what we're doing. And this was by Dr. Bryan. And he basically, in the anesthesia literature, in 1982, published the first evidence that how oscillators can allow, an oscillator device can allow for ventilation. And this is the most recent picture of the 21 and 0 week baby, 285 grams, and 18 months old, which should be, which is for him like 13 months adjusted for prematurity. And so it's not unexpected that he needs some nasal cannula oxygen, but he's doing so well, he'll probably be off of it before he's corrected at age 2. So thank you, and I can stay on to try to answer questions to the best of my ability. Thanks.